summertime with amputations of both legs above the knees. And then both of them lived only about a year after that. And it was pretty devastating. And of course, I put on my advocate's hat and I went to the hospital involved and I said, why did you do this? Why didn't you keep them longer? Why didn't you provide them with medication instead of just giving them a paper prescription? Because this was just prior to the Affordable Care Act being launched and prior to expanded Medicaid. And I was told something that actually stuck with me quite a bit. And it said, but Elizabeth, we're not a shelter. We can't keep people indefinitely. And that's your job. And we need to maybe work together on this. And I thought, you know what? They're right. An emergency department or inpatient hospital can't keep somebody indefinitely. If you need to mute, I'm hearing some background noise, so that would be great. Thank you. Okay. So, well, what is this recuperative care? This is the official definition of it from the National Healthcare for the Homeless Council. And if you're interested in recuperative shelter and finding out a lot more about the nuts and bolts of operations, the National Healthcare for the Homeless Council is an awesome resource. You can visit their website. They have everything from full policy books that organizations have shared. And you'll find this group to be just very accommodating and being able to answer questions. And recuperative care looks very different in different places in the United States. So what we're going to do is we're going to talk a little bit about what constitutes, according to the National Healthcare for the Homeless Council, quality recuperative shelter. But it doesn't have to necessarily look the same. So in Florida, for example, a recuperative shelter is actually housed in tents that are in a park. And in Boston, it looks very medical because it's in an old hospital. And so, and they have a medical director and it in actually more like a nursing home. So there is a spectrum of services and there is something that I'm sure could fit into what you have. So the other thing is medical respite and recuperative care are used interchangeably. So you'll hear me use them both. It describes the same service. And actually, National Healthcare for the Homeless uses medical respite more often. But I was advised by our Oakland County Health Division a long time ago to use recuperative shelter because they were concerned that implying medical respite implied that we were more of a medical facility than we actually were. So these are the standards. And as we're looking through them, you're going to see it's pretty much describes standards you would expect for any shelter: quality and safe accommodations, quality environmental services, um, and also manages that transition from the hospital and also or from a specialty care, because we accept people coming not only as discharged from the hospital, but also they may have an interim discharge to a nursing facility, and we'll continue to track them if we know that they're going to ultimately come to us. And then the clinical care. And the clinical care includes making sure that the individual is connected with the kinds of services that they're going to need. So connecting them with medical care through maybe a federally qualified health center, connecting them with mental health care where appropriate, connecting them with other kinds of services that can also enhance their quality of life, and of course, connecting them with housing services. And while an individual is in a medical respite or a recuperative shelter, they're usually in the building 24 hours a day. So they're round the clock. So that actually provides an advantage. You can provide more intensive services. You can help them carve out time where they're actually looking for housing to help resolve their homelessness, and make sure that they have all of the things that they need. And then the last part about quality improvement is really important. So we're going to talk a little bit about that a little later on in the presentation. So this is a little bit about what hope looks like. And I'll show you some pictures in a minute. So we launched in 2015. So we now have a 5-year track record. But prior to that, for maybe 3 years prior to that, within the shelter, we sort of had a recuperative shelter at the same time that was just a small portion of our emergency shelter that we operated. And in 2018, we were able to move to a different building where we were able to expand to 15 beds. So this is discharge to home. And I want to make sure that discharge to home is something that is of critical importance because often discharge planners are going to look for the most expedient route to discharge somebody. And a shelter is much easier to discharge someone to than going to a nursing home. So you have to be very strict about your what you're going to accommodate because they may discharge somebody to you that is not appropriate. And we will talk a little more in the presentation about what discharge to home means, but you can also accept home health to help with things. Like we tell them we are a facility that is not going to touch the patient. So when they're discharged to us, we're not going to bathe them. We're not going to help them with toileting. They have to be independent in their activities of daily living. We provide complex care navigation, and that is a real intensive navigation. Are seen by their case manager, which is the navigator in our world. They're seen usually minimally 3 times a week for about a half hour. And they're discussing all kinds of things, like what kinds of services do they need. So once they've done the VI SPDAT, the navigator has some ideas of maybe services that might be helpful. And a lot of times that's helping them understand how the services work, getting their agreement to partake, for example, in mental health services, if that seems to be an issue. And then we have public health nurses. Public health nurses also at the front end prior to the pandemic. We're hoping that once the pandemic has been resolved, we'll be able to have our public health nurses back and helping us where they would actually go visit the patient in the hospital. So they would also give us some feedback as to whether the patient was appropriate. We have registered nurses that work for us that provide a lot of patient education. And again, we'll talk about that. And our discharge to permanent housing rate directly from the recuperative shelter, or if they have met their medical goals, they may go to our emergency shelter for a little bit, but it's about 85%. Now, we are not a housing agency. We rely on community partners for housing, but that is something that that we're very proud of, and it also speaks to the fact that the more intensive the services, the better the outcome. And then we are not a destination for COVID positive or those with communicable illness like flu. We actually have a separate facility for that. So this is what it looks like. This was actually a former dentist office. So it already had the little rooms all carved out. And so we're able to give people some privacy. And you can see we have very lovely gardens in the back. We had a group that came in from Leadership Oakland that built the gardens, and then a church built the pavilion. And I will tell you, these are well used. The guests really love their yard. And it gives them a nice quiet area to go and they can come and go. They're not just stuck in a building. And even when it's cold and snowy outside, we shovel a path so they can get to the pavilion, because not only is that the destination for those who choose to smoke, it's also just a place to just be outside and to sort of be one with nature. So this gives you another look at what the facility looks like. We have showers. We provide 3 meals plus snacks, clean bed linens. All this environmental stuff is all part of the standards. But if you already operate a shelter, you know you do this already, providing a place for people to store their belongings and things like that. So this is 24/7, 365. So staffing is more intense, but it's a smaller program. So that part means that We don't necessarily have to have, 4 or 5 staff. Usually a couple of staff are sufficient to be able to meet the need. And we have the nursing support. We have support through a federally qualified health center in our area. And that FQHC is a wonderful partner. So in non-pandemic times, if we have somebody who is having some kind of symptoms, whether it's related to what brought them to recoup or something else, we're usually able to get a same day appointment and they will send a cab. We've been able to arrange that for them. But now with pandemic times, we're using telehealth a lot more. So we're able to let them know that we need telehealth. We know in the afternoon, they save a block of time for any telehealth appointments. And they are also in the process of setting up, I think it's going to begin actually in November, having in where they will actually see everyone in the recuperative shelter via telehealth. They also have a care team that they can send out to the shelter that is also being deployed beginning in November. So the community partnerships are really, really important. And I'm sure that for those of you who work in shelters, you've seen that your shelter has developed a lot more relationships with community partners. And these are things that actually will be good and carry over into the future as well. Our framework is also driven by a policy manual where we have policies. We tell people no freestyling, our staff, that there is a reason why we have everything set up the way we do, and we expect that they're going to follow that. And then we also do safety drills the same way that, again, that you're going to do in a regular emergency shelter. We have a cleaning checklist, which has gotten even more robust with COVID and infection control protocols. In our shelter, the guests are also able to wash their clothes there so that they're able to maintain their own personal hygiene as well. Um, we have oxygen storage. So, because a lot of times COPD is one of the biggest reasons that people go to the hospital in the homeless population. And so often they come out and they're on oxygen and they have a concentrator. So you'll need a green box in order to be able to store the oxygen tanks. And they're expensive. They're $1,000 or more. But what we did was we partnered with an organization of nurse practitioners in Michigan, and they were able to give us a grant for that and also for the AED. And you'll see the little white boxes also in the AED box, and that's our naloxone. And down below at the bottom, you'll see where it says F1 and D1. Those are the individual boxes of medication for each of the guests. So they have them. There are some things that are more routine that they will come and take. It's kept in the staff area to make sure no one else takes their medication, but they can have their medication on a schedule and the staff person will get their box for them. If someone has a controlled substance, however, they have to sign it in and out, and there's a count protocol as well. Some pharmacies also have blister packs that you can get. So we encourage them as much as possible to use pharmacies that will have controlled meds and even all of their medication in blister packs, because that makes it really easy for them to be able to um, take their medication, to know that they've taken it, because sometimes they come and they'll say, well, I'm not sure if I took my medication or not. And it's especially critical. Now we know because we write it down, but it's especially critical for when someone moves to a home of their own to have a way to track whether they've taken their medication. So we've used day of the week containers and things like this, but now with the blister packs, that just makes it so much easier. And we will help set them up with pharmacies that deliver, and they will continue to deliver to them once they move to a home of their own. So we have a pre-admission process. And during the pre-admission process, the hospital or the other referral source could be a health plan, will call us and will let us know that they have somebody who is a possible candidate for the recuperative shelter. So these are some of the kinds of questions that we're going to ask, and also advising them that when they're discharged, we're expecting that they will be discharged with prescriptions filled so that they will have that 30-day supply of medication. or if it's in the case of an antibiotic, the amount that they need to take. And any assistive devices will be provided, medical supplies, that they will also be set up with home health, especially if they need something like physical therapy or they need wound care, that they're going to be able to do that. We're going to also ask them for things like the nurse's notes, labs, other patient information, and some history, and the discharge summary. The public health nurse in pre-COVID times would be notified and would actually go visit them in the hospital, because this is also voluntary. And so while we have our checklist, we also have people in the hospital that really want to know who the shelter is, what we're going to do. If they've had a bad experience with a shelter, they might not be thrilled about coming. And so, what we want to do is help build their confidence from the very beginning. And then the public health nurses also do come to the shelter at least once a week, and meet with some of these guests about some navigation issues, mostly with their insurance company, like, are you having problems getting rides, and helping them learn how to use some of those tools. But that nurse will also continue to follow them after they've moved to a home of their own. So our criteria, um, I mentioned before the ADLs, they have to be independent in ADLs, but the principal diagnosis has to be medical. This is not a discharge from a behavioral health floor. From a behavioral health floor, they can be discharged directly to our emergency shelter. Sometimes that gets a little muddied. So, for example, we had someone who had anorexia, but it caused a lot of medical issues, and she was actually being tube fed, which she was able to do herself. Again, we're not going to do that, provide that. So, even though she was on a behavioral health floor, she also had been on a medical floor, and so we did accept her. But if they have a mental health diagnosis, we also request that they be as stable as possible. And they have to be literally homeless. We had some folks that were trying to discharge to us because we were easier to get into than a nursing home, but they were people that lived by themselves and actually had a home of their own. So we tell them that is not our bailiwick. That's not what we do. And we don't accept people with IVs, because we don't have nurses there around the clock. And we are expecting people to be independent. That requires a different level of licensing. And then we don't accept people with contagious diseases, including COVID at that particular site. We do have another place for them, which is a motel site. When the guests come, we also have a guest contract, and that just reminds them of conditions of stay, what we're expecting from them. And we're expecting them to stay in. We're expecting that if they go to their doctor, they're going to come back to the shelter, um, that they're not going to bring all of their earthly goods with them, but that they limit their belongings to one bag, that they're also going to meet with the nurse. And that's a really important thing, and meet with our navigator, because sometimes they come there and they sort of move in and they go, well, this is nice and the food is good and I really like the people, but they don't want to meet with anybody and they're really resistant. So we tell them up front that that's an expectation that we have for them. Usually that gets worked out, but it sometimes takes a little bit of time. We have that partnership with Oakland County Health Division, their homeless advocate program, which is where the public health nurses originate. And so these are some of the things that they provide, are that the in-person assessment in the hospital. And they help the recuperative shelter, Hope Recuperative Shelter, and the partner hospital determine the appropriate placement for the patient. Sometimes they'll say, you know what, we really feel this person would benefit from a supported nursing facility first. And so they have eyes on that particular individual. Or sometimes our nurse will have a concern because perhaps the individual seems like they need a lot more supports, but it could be that we're looking at earlier nursing notes and not the more recent ones, and they're able to say, oh no, they're able to ambulate, they're able to bathe independently and things like that, and reassure us. And the most important thing is they're able to work with the patient. They will talk to the patient and and talk to them about why a place like Recoup could really help them, and talk to them about um, helping to find their way home, and helping them talk about how important that is, with housing as being part of their healthcare plan. Um, so our service coordinators are what we call our direct care staff. And these are some of the disciplines that that they have. And so a lot of them have completed the community health worker, um, the community health worker curriculum. And so they are also able to be able to help them navigate the community and help them find the services that are important. They also liaison often with the staffing at their health plan, because their health plans also have complex care nursing, and so if a person needs a lot more supports than they're getting, the health plan is also a good resource. Our staff are trained in things like AED, use of AED, CPR, naloxone. They're trauma informed, and they approach their services with the guests from a trauma informed approach. They're also trained in mental health first aid and de-escalation. And I will tell you, our emergency shelter is it sort of like reminds me of an emergency room. There's something going on all the time. There's a lot of movement. There's lots of noise. When you go to the recuperative shelter, it's like it's very tranquil. It's very quiet. People are busy doing things, and it just makes it a difference. It's kind of like a very different culture. And then we also have a training plan for our staff, certain times that they are retrained, and do updates to some of the trainings that they've had. So our navigator, 2 to 3 times a week. He actually, Dave, who's pictured here, just recently retired. And so we have a new navigator who's a woman. So we replace that with her photo as soon as I get one. But they help the guests obtain vital documents so that they can move forward with housing. Um, they help them with setting their housing goals, and applying for benefits and all of those other things, and liaisoning with different agencies. Often we find that people who are coming to the recuperative shelter may need APS, Adult Protective Service involvement, because it could be that they have income, but they may have a family member who is taking the income and keeping a vulnerable individual homeless. And so we're able to help interrupt that too. So the navigator is looking at all aspects of the social services, in working with the individual. And then the nurses are looking at the medical goals. So they're going to provide medical oversight. A lot of times, especially with people who have diabetes that has worsened, and they've had hospitalizations because of diabetes issues, the nurses are able to monitor things like insulin, because they might need more insulin when they're in the hospital, but now that they're walking around more, eating more regularly, their crisis level of insulin might need to be monitored. So they will work with the patient to call the doctor to be able to do that. And then they provide them with health education. This is a population that does have, on the whole, poor knowledge of health and health interactions. And they tend to have remedies that are sort of homemade remedies. I can tell you a lot of people have a lot of faith in things like the apple cider vinegar and things like that. So, as a remedy for pretty much everything, because that's something that's accessible to them. And then we're going to make sure that we are connecting them with a primary care physician. So, and then when they're connected with a primary care physician, often the nurse will be on the telehealth call with them as well, or calling in if they're doing a face to face meeting, if they have concerns that the individual is a poor reporter. So this is our nowhere to go form. And we liked it so much at Recoup, we actually are using this in our emergency shelter too. So this is kind of a triage form that helps people understand, based on their own issues, where to go when they have some particular problem. Because for most of the folks, even when they have primary care, they don't really know how to navigate that. And if the primary care has a press one, press two kind of system, they sometimes get frustrated with that. And so they tend to default and go to the emergency room. I'm sure that if you work in a shelter, you know how many times the ambulance shows up at the shelter. And often it's for things that can be taken care of in a doctor's office, or a prescription that a doctor can call in and have delivered to the shelter. So the kinds of things, so we have like typical things that you would that you would go to the doctor for, that would be listed, but also where it has other, we put something maybe specific to them. It could be, so we had an individual, for example, who went to the emergency room a lot. I think it was 66 times in a year. And when he came to our shelter, he came to our emergency shelter first. He went 3 times in one day. And we decided that we would transfer him over to Recoup with his permission, because we told him we wanted to help him get better. And what we discovered was he had this issue where he believed he couldn't breathe. And so we ended up helping him through our nurses learn how to use a pulse oximeter, which now is famous, but back then I had to be educated as to what that did. And so he could monitor his pulse, the oxygen level in his blood, so that he knew whether he was truly in respiratory distress or whether it was an anxiety attack. And it helped him be able to strategically make the decision to call his doctor, as opposed to just calling 911 and going to the emergency room. And actually, when he was discharged from Recoup, we discharged him with his own pulse oximeter. And he still is best friends with his doctor because he does like to go to the doctor a lot, but it's a much better system than going to the emergency room. We have all kinds of other forms that we've developed as well, for medication oversight, and also for insulin, and just so they initial when they take things. So we know when people are taking their medication, that we also know that they've taken it. These are some of our community partners. You'll notice it's a mixture of health, mental health, and hospital partners here. And these are in folks all in the Oakland County area. So the reasons that people would be discharged from Recoup, it's pretty easy. They've either moved to permanent housing, or they've completed their medical goals and they've moved on to the emergency shelter until they find their housing. So they're continuing to look, or occasionally the noncompliance and self-discharge. And actually, in the Recoup Center, that is very few. If we have one person a year that decides that they're leaving, that's really a lot. We really don't have that happen very often. So we also, I talked to you earlier about quality. We have length of stay meetings, and weekly quality meetings that are run by our quality manager. And they're interdisciplinary. So the nursing, somebody from nursing, somebody from the navigator, the shelter manager, all meet about and do a case conference and their progress towards their medical and their housing goals. They discuss what the client barriers are, and they also work to see what else they might need to do to make a plan. And then these are things are discussed by the navigator and the nurse with the individual as well. But a lot of this is to keep us on track. It's not an issue with the client, but sometimes the squeaky wheel gets the grease. And so a client that's more vocal, there may be more effort, for example, with getting them housed. But we really need to, this kind of helps level the playing field to make sure everybody is working towards that goal and that we're helping them in the same manner. So this is a really important part of this, funding. Um, and I know that nobody wants to start a program, no matter how worthy and how great and how wonderful the outcomes, until they actually know what the funding is going to be. So I have kind of a funding plan here. So to access a new system, you need a door opener. So I will tell you that I don't travel in the same social circles as the CEOs of the hospitals in our county, but I know somebody who does, and that's the person who is the it was the head of Health and Human Services in the county, which is not the same as MDHHS, but it's the health department, the juvenile justice system, community and home improvement, which is a housing and affordable housing area. So they have a lot of different divisions underneath Health and Human Services. And so I met with him, told him about my idea about starting a recuperative shelter, but we needed some money to get started. And according to National Healthcare for the Homeless, they have a lot of helpful hints about this on their website. And so the National Healthcare for the Homeless Council talked about importance of funding through hospitals. And so hospitals have funds called community benefit funds. All hospitals have them. Right now, with COVID, those funds are somewhat encumbered at this point because there are a lot of people that have been going to the hospital who may not have health insurance. But before, they were used to help people who were in the very poor category who are now have insurance through expanded Medicaid. And so I mentioned before that there was a the two men that each cost over $1.5 million. So one of the things you want to do is figure out how to build relationships and to work with them. And that door opener is going to be critical because when somebody goes in with you and says that they trust and says, I think this is a good idea, that's going to be really helpful. And you also want to prepare a brief, something that shows maybe a story about a client that might be a mutual client, a patient of with that hospital is going to really, really be critical. Okay, so our launch funding. So we're going to target the hospital C-suite. You can talk to all the social workers and the nurses in the world, and they will love your idea, but they don't have any power to do anything. So when I went to one of the first hospitals I went to, it happened to be the hospital that had served the two men that I spoke about at the beginning of the presentation. And I had like infographic that I had made up about this, and I had estimated what I thought um, they had cost the hospital. And I said somewhere probably around $1 million. And the hospital CEO looked at me and he said, actually, each one cost $1.5 million. And he named who they were. And so then I was kind of surprised and I said, well, how come you didn't do anything about this? Why didn't you have, make sure that these individuals were able to be, um, have medication discharged with them and things like that? And the hospital CEO said to me, because it didn't get to me until it got to be acute. But he understood that providing a grant of, say, $50,000, which is a lot in shelter world, but not a lot in hospital money, was way cheaper than having one or having two individuals in this case cost them $3 million. So these are important points to make because you want to show the cost benefit to the hospital in order to be able to get an annual and repeating grant from them. We all have examples of super utilizers from our shelters, and those are the ones, and we know which hospitals they like to go to. If you only have one hospital in your area, it makes it easier, but you're able to be able to get their buy-in. And the other part that's important for their buy-in is to be able to open up that referral process. Um, the referral process is going to be critical to making sure that you do have people coming. It's not because the need isn't there, it's because they don't know to they don't know that you provide the service. So you want that because you're going to also be providing them with information about what the outcomes are. Make sure you leave your proposal behind in a business card. And I always follow up when I get back to the office with a little thank you email. And that really makes a difference. So the other thing that you'll also want to do as you're putting your funding together is look at health focused foundations. Metro Health Foundation actually funded a study that we did the first year, which was really important because as we're looking to get health plans on board, that study also shows what it is that we can do. We're not sharing studies from the National Healthcare for the Homeless. We're sharing studies that actually have cost money from these particular providers. Um, Blue Cross Blue Shield Foundation provided us with money. The Jewish Fund, which is the Sinai Hospital Fund money, they fund health programs. All of these, there's a lot of them. And if you Google health foundations, you'll find that there's quite a few. Um, you also can use some funding from traditional funders, ESG, ESP. So you're going to be cobbling together pretty much like you do in your emergency shelter, a lot of funding streams and faith communities, medical professional groups. A lot of them will pay for certain things or sponsor something within that your organization. Um, Social media is really helpful, especially if you're fundraising for something. World Medical Relief is a wonderful organization, and they have hospitals usually recycle their equipment every 3 years, and so they donate it to World Medical Relief. And Medical Relief often has items that they are able to send over to us, including things like a Dynamap, which is that portable a blood pressure machine that they use in hospitals and things like this. And then work with hospitals and work with clinics because sometimes they can roll some of the items that you might need, like PPE items, into their budget, and either you pay their price because they get a really good price, or they may do that as a donation as well. And we talked about the community benefit funds. We are just beginning to do Medicaid billing. It's been, we get a lot of, boy, this is a great idea, but I don't know how to do it because this isn't something that is readily apparent within the Medicaid code in Michigan. So we now are working with United Healthcare. We've got a couple others that we've been talking about, but getting that United Healthcare on board it took us about 2 years. We are in conversations continuously with MDHHS, and I think they're understanding now that we have the 5-year track record. There are a lot more recuperative shelters that have come on board. I think 3 in Detroit. Dan Kelly, who's on here, he has one in Washtenaw County, and there may be some others in the state. So they're seeing that this is a really, really good service that has actually saves a lot of money. And so just like we did with the hospitals, we're also talking with health plans and with Medicaid about the cost savings that we can provide. And all 3 of these things are areas where you can use for sustainability funding. Community benefit funds, we ask for them every year from the hospitals. Sometimes it takes a little more than a year to get them because the process is a little convoluted, but we've learned to give them a lot of lead time as to when we want the funds to be able to hit our bank account. And they've been very good about that. The hospitals actually are quite excited about being part of this. And often when they're talking about some of the things that they're doing in the community, because community benefit funds are supposed to get the hospital out of the 4 walls of the hospital and into the community and bringing health benefits to the community itself. So they are now looking to partner with more agencies. As I said, this year will be tricky because 2020 is the anomaly, but hopefully as the COVID virus gets more and more under control, hospitals will go back to some normal um, uh, procedures and they won't be inundated with so many folks that don't have health insurance. And then they'll be able to use community benefit funds again for community benefit, especially with helping to support recuperative. And then some of those medical foundations that I mentioned in the launch, um, as launch funding, some of those also can provide regular funding as well. So here's that study that I talked about a little bit ago. So we decided to use explanation of benefit forms. That's that form that your insurance company sends you on a monthly basis that says, here's how much we paid, here's how much your copay was, here's what we negotiated down from the original cost with the doctor. So we were able to get 20 people in year one to give us their access to their explanation of benefits. It was a little tricky because we saw something like 100, I think, the first year in that particular site, but 20 was all we could get, the pre and the post uh, EOB information. So 2 months prior to them coming to recoup, they cost the insurance companies from going to emergency room and over again, $187,532. It's a lot of money for 20 people. And then some of them were inpatient. And so that also had, there was some inpatient costs. But at the end, 60 days or 2 months after they were discharged from recoup, the same cohort cost only the insurance companies only a little over $13,000, and that was mostly pharmacy and doctor visits. And keep in mind, these are people that have complex medical needs, so they are going to go to the doctor more frequently. But if you look at the difference from 187,000 and 13,000 for the same cohort of people, that's really impactful. If you look at the National Healthcare for the Homeless Council website, they have lots of studies that they've done that show this, and some of the studies go back 20 years. It's really something that shows for this investment, this really pays a very high return on investment here. So here's some of our lessons that we learned. Um, we always provide our hospital discharge planners with that written information on the criteria for entry. It solves a lot of problems up front. And we ask them to fax the health information to the shelter prior to entry. So they can't just put somebody in a cab and send that person over to recuperative. We tell them that we want a little bit of time to consider. So when the person is admitted and they ascertain that the person is homeless, they start that process then. They may not even have an exit date, a discharge date. And then we also make sure that they know about filled prescriptions. Now, hospitals have a lot of turnover. There are people coming and going all the time. And what we found is that doing something called lunch and learns, where we set it up, and we were doing these in person, we've now switched over to Zoom. But we have anybody who is interested in this can come and find out about recuperative services. But we also use this as a two-way street where we say, how can we do better? And they will talk to us about different things. So most times they're going to tell us, oh, you guys are great. I had this really complex person and you were able to take him, and and he seems to be doing better, hasn't even been back in the hospital, since he was discharged from here. But every now and then you get somebody who will tell you something that's really important for you to know. It was really difficult for me to navigate that. And so we say, tell us specifically what it was. Well, it was on the weekend. Well, we tell them our person who's making the determination isn't working on the weekend. So when we tell them that, then they learn, okay, I have to bump it back a little bit, or I have to wait till Monday to do that. So that helps them not get frustrated. Um, but once we train the hospitals to follow this protocol, and then we keep retraining through these lunch and learns, we find that this has been a really, really helpful and excellent process. This has really helped. Um, And the other thing too is that hospitals understood that they could send somebody to a supported nursing facility prior to recoup, and we would still accept them because they were really reluctant to do that, thinking often what happened was they would discharge to a nursing facility. The nursing facility would discharge them, but they still had more mending to do, and they were back in the hospital again. And if they came back to the hospital before 30 days was up, they often were not able to bill Medicaid. So therefore, they were eating the cost. So we were able to help them with that. Um, the the discharge planners that we work with are absolutely wonderful. They make sure the prescriptions are filled. They make sure the equipment is ordered, but we also remind them and we work together on how to be able to do this. And so the hospitals also will do all of those things before sending that person to the nursing facility, because then the medication will come with them from the nursing facility over to the recuperative center. And then making sure that people were fully informed about what recuperative was, and the fact that we would expect them to not just stay in a room on a bed, but to participate in their recovery, and that they would see the nurse and that they would see the navigator, and they would participate with all of the things they needed to do for housing. And all of this happens not necessarily on a time frame that we're driving, but based on how the person is feeling. We also have a lot of people in the recuperative shelter that are people who are um, that have cancer or have some kind of compromised immune system that can't be in the regular shelter. It's a really quiet, tranquil place for people to go to be able to do that as well. And so I have closing with a picture of Wayne. And Wayne is sitting courtside at the Detroit Pistons game. And Wayne is a Pistons super fan. He loves, breathes everything. If we can find a t-shirt with a Pistons logo on it, we knew that it would go to Wayne. And Wayne also has terminal cancer. And so one of the other things that we try to do is if people who are in a situation like that have some kind of wish, we try to see if we can help them have that fulfilled. So he got to go to a Pistons game. He got to sit near the players. He got to meet the players, and he got a tour of their new facility and was absolutely thrilled. And so that was something that was absolutely one of the highlights of his life, and he never stopped talking about it. So, with that, I'm going to open it up to questions. And I guess, Dan, are there any questions in the chat box?
Yeah, yeah. Hi, everyone. So I don't see any questions in the chat, but if you want to add any, we can certainly answer those. We got a little bit of time left here. Thank you, Elizabeth, for the great presentation.
Oh,
Um,
my pleasure. And
yeah,
and
does
I know
anyone
I
have any
went through this
questions?
quickly because there's a lot of information, and because it's being recorded, I understand that, if you wanted to look at the PowerPoint again or review it, that will be available as part of the recording.
Yeah. Does anyone have any questions though they want to add in the chat or raise their hand and ask away?
So on this screen too, I also have my contact information, my office number, and my email address. So a lot of times afterwards, you think, well, I'm not sure about this or that. We're very open to doing this. Normally, we would say, come over and we'll give you a tour. We have to wait to do that for now, but we're also happy to do a Zoom meeting with you and to be able to talk through some of the particulars. And a lot of the organizations that have developed recuperative services have also asked us for things like to see our policy book, or to and have asked us, what do you do in these circumstances, or do you have forms? I showed you the medication forms and the nowhere to go form. Those kinds of things are helpful, and we borrow from one another. And we got a lot of our information to start with from the National Healthcare for the Homeless Council, as I said, they have a lot of great information on there as well. It was helpful for us to get this launched, to have a community committee that was led by the health department, and they were able to help us get started, and they invited hospitals. So we were able to work with hospitals to make the process as friendly to their discharge plan as possible, and so that they understood our abilities and limitations as well as we understood their abilities and limitations based on the conversations that we had. And we talked for probably about 18 months before we settled on a model, and then we're able to get started on that. We started with the funding, and in about 2 years, we were able to actually have all that put together. And we were doing it from scratch because we were the first in the state. So, now they're getting to be the recuperative medical respite type of shelter is becoming more common, and so that's something that is helpful. And big systems like McLaren, the St. Joe's Trinity Health, and the Beaumonts, they're all very, Henry Ford, they're all familiar with this model. And so they're willing to talk about it because they've already worked with us. So that's something that also can be very helpful. Any questions?
Hi, this is Allison Green. There are some questions in the chat.
Okay. Dan, can you see them? I'm going to escape.
Okay, I can read them for you.
Okay, if you can read them, that would be great. Thank you.
Yeah. So one says, I noticed that one of your sponsors is MORC. Have participants in the recuperative shelter discharged into the My Choice Waiver Program or get referred to the local Center for Independent Living with their nursing facility transition program, or now called Community Transition Services? It is a Medicaid billable service, and the navigators do similar things to what your navigator does.
Yes. So we're helping them. The transfer happens as they're exiting the recuperative shelter. And actually, even before, we try to get them involved. And so if they're going to be involved with the system, to be able to work with them, especially for housing that might be like AFC or something like that, some kind of supported living situation, then we will actually defer to them as we do that. So yes, but and with the mental health providers, we're also working with them so that they're going to be able uh, we all agree that, on the appropriate type of housing for the individual if there's a question about that, and so that they'll be able to provide support services once that individual moves to housing, because that's a critical part. Good question. Thank you.
So the next question is, how are persons in the recuperative care prioritized for permanent supportive housing?
So we actually work with our with the housing agencies. We meet twice a week. Our navigators meet with them, and so they are prioritized based on their VI SPDAT score, but they're also prioritized based on other things. Maybe their complex medical need may, help them move up, but they actually are, and they're discharged not only to PSH, but also they may have a Section 8 voucher or other funding streams. It's not just limited to one kind. So just like the regular shelter prioritization, they actually enter the queue and are prioritized based on their need.
Okay, the next question is, do you have an average stay or a limit on how long people can stay?
So our average length of stay is 4 to 6 weeks, because it could be somebody who's post surgery or maybe with a broken leg that might need that much time, but it's based individually on their medical goals. We have had people stay longer than that who have cancer, because we're not going to put them in the regular shelter, because if they're actively getting chemo and others, they will be exposed to more things in a more crowded environment. When we're working with a health plan, they want everything limited. So we have to every 2 weeks get approvals. There's an approval process for that. We still try to base it as much as possible on the individual's need.
Okay, sorry, it's a little loud here. Then there's two more questions I see, which the first one is, are you willing to share your forms? And the second is, how do you become a Medicaid billing agency?
Okay, the first question is easy. Yes, we'll share our forms. And the second question is persistence. You have to, just like I said with the hospitals, you have to be able to know, to get in to talk to somebody who is a has the ability to make decisions. And so for United Healthcare, we were able to do that. Plus, United Healthcare has a national interest in medical respites and recuperative shelters. So they already had, just like Trinity Health is a big sponsor of them as well, they were the easy ones, and it still took us 2 years with Trinity. One of the things that we're working on right now is working and having conversations with MDHHS and other groups are doing the same thing, to have this as a covered benefit for people who have expanded Medicaid. If that happens, then it won't be a problem. We'll just be able to get on the panel, and it becomes a covered benefit that you're able to bill under. The issue is, this is not a traditional looking medical type of service. So they are in the process of trying to figure out like and that's what took us so long with United Healthcare. It wasn't that they were a reluctant partner. It's like, how do we make a shelter a Medicaid billable service? Because we are most definitely a shelter, and we make that distinction. We're not a nursing home, because then that requires licensing and other kinds of accreditation and things like this. And so they're talking right now with Medicaid on what does that look like that can accommodate this billing and not meet some of the other criteria for services. So I will suspect that in the next year or so, you're going to see a lot of movement with that. They're working on the nuts and bolts on how to quantify that. So in the interim, we're working to get in the door to at least talk to somebody who's in the leadership level of the health plans, and doing presentations and letting them know about our services. I can tell you the community health workers that work for the health plans love us, and they understand the benefit, but they're just not able to elevate it within the organization. So it takes a lot of persistence. And that's usually, I write those kinds of emails on my spare time, like on the weekends, asking for appointments and sending them our study and sending them information about, the kinds of differences that we can make to their bottom line, because they're definitely interested in the humane part of what a recuperative shelter brings, but they're also interested in how this affects them economically. So
And
the answer is, it's complicated.
and one more question did come in during that one, where someone asked if you have a veterans preference or a vets only wing of your facility.
Our facility is very small because but we have veterans that come, and we work with veterans in both shelters. And we've not had any waiting list for our recuperative shelter, because we almost always have someone coming or going. And so we're able to move as people meet their medical goals, but they haven't achieved housing yet. We can move them to the emergency shelter if that's appropriate, and we'll have a bed open. So haven't had to work on a preferenced area. At some point, I'm hoping that we'll be able to grow the program and be able to do some specialties like that as part of it too. Other questions?
Elizabeth, what's one thing that if someone was interested in like thinking about this idea in their own community, what's the first thing you would recommend that they do as on their journey to assessing the need and opening a recuperative care shelter?
So I think there actually are two things. I would start with both the local hospitals and the health department, because the health department can possibly get you in the door of a decision maker at the hospital, but starting that dialogue, for us, creating that committee that consisted of individuals that were appointed by their hospitals to be part of that, plus the local clinics. It not only helped us solidify our plan, but it also helped us identify community partners that beyond that committee are really helpful, especially having FQA and FQHC as part of the committee was helpful, because they then say to us, how can we support you better? Because we are a referral source for them. And so they're able to help with that. But the having somebody who can open the door is very critical. So that's why the health department has a lot of power in an area, and they're able to, and they have an investment in housing as healthcare as well. As health departments are evolving, they're providing a lot more in the way of support to vulnerable populations to make sure that they are able to stay healthy. And there's a lot of initiatives around healthier communities too. So it's all part of the same thing.
That's great. Thank you for sharing that. Any other questions, anyone? And I apologize, I can't see the chat box. So for who's reading that, thank you so much.
We appreciate it. You're our honorary moderator.
Yeah, I can't see the chat. So are there any other in there?
And I can't see it either. So
nope, there's no other ones in there. So I think we're good to go.
Great. Thank you so much. If anyone has any final questions, definitely drop them in the chat now. Otherwise, I believe, Elizabeth, you shared your contact information, correct?
yes, I shared my contact information. And if they go back and look at the recording of this, they'll be able to see it again if they want to fast forward to that information as well. And if you have other questions that you think about and you put it in the chat box, while people are checking out, I can get that information and communicate. Put your email in there, and I'll be happy to send you an email with a response if I have the answer. If I don't have the answer, I'll tell you that too.
Well, thank you, Elizabeth, for this great presentation. I hope everyone was able to learn a great deal about recuperative sheltering, and it's something that we need across the state. As Elizabeth mentioned, anybody has any questions, feel free to reach out to her. And I will say just real quick regarding the recording, we will we'll make sure to edit that because of the technical issues that we had during this. I hope we can do that. And then otherwise, anybody who's here for CEUs, I noticed there's at least 5 of you. Please, in the chat box, make sure to note that you're checking out now so we can give you credit for your CEUs. Otherwise, thank you everyone for coming to the presentation, and look forward to the rest of the day today, the last sessions.
Thank you, everyone.
Thank you, Elizabeth.